Hi, I'm John Hart. I work with the University of Melbourne as part of the Extended Technical Advisory Group supporting Papua New Guinea.
Hi, I'm Viola and I'm a general pathologist by training, but I'm working with Melbourne University with John, supporting John and our D4H work in PNG. As a country, we don't have reliable sources of data for death, and our levels of death registration are so low that you can't make very much out of it anyway. So it was very important for Bloomberg to come to PNG.
No, just the huge challenges, like going to different districts, it's so different, and the remoteness and having to go a long way down bumpy roads and then a long way in a dinghy to get to the sites we go to has been a real challenge, and it lets you understand why it's such a challenge to get notifications in, and how much work there is to do to get towards the goal of 100% notification in PNG.
Logistically, it's very challenging for our ward recorders and our health workers, and transportation is not easy, access is not easy, and so these cause delays in the health facilities receiving notifications, as well as the time it takes to do a verbal autopsy once the notification is received by the health facility. We understand that these issues cannot be resolved immediately or in the short term, but they are challenges that we hope will help us to work out ways in which we can be a little bit more innovative about our approaches and going forward.
Yeah, the CRVS system was really quite dysfunctional in PNG until this process has started with D4H supporting getting notifications of births and deaths and starting to improve MCCOD. MCCOD stands for Medical Certification of Cause of Death. So this is when doctors in hospitals and health facilities write a death certificate and get verbal autopsies as well from rural areas. So it's a process that's really starting now and improving, that really didn't exist before.
Yes, also generally strengthening the CRVS system, so basically the government structures that are in place to support registration of births and deaths. That has very much grown since Bloomberg came to PNG. Firstly, much of the work was focused on getting the government agencies that are responsible for strengthening the CRVS activities to work together and to come to an understanding of what this is all about. They were very much unaware of how important it is, so that process took quite a while, at least 2 to 3 years, I should say. So I'd like to say that we acknowledge Dr. Moya's efforts and Professor Ian Riley in getting that to the place where it's at now comfortably, where we are able to implement MCCOD and VA. Since the establishment of medical education in PNG, there's never been any MCCOD training done officially. If there were any done unofficially, then we are unaware of that. And this is quite clear because the quality of the medical certificates of death that the PMRB receives are quite poor. PMRB is Performance Monitoring and Research Branch at the NDOH, and as a result of Bloomberg, one of the interventions has been to improve the quality of death certificates, and we have so far trained more than 300 doctors, HEOs, and medical students in total, so that's pretty good. Two things that we'd like to achieve with the rollout of improving quality of MCCOD data is, one is the training of doctors, HEOs, and medical students who are currently in the workforce or entering the workforce, and of course having the curriculum within the medical education system so that upcoming doctors, HEOs can get trained. So we are hoping to get it as part of, to have it as part of our postgraduate training as well. So this can be sustainable and not just for the period of time where Bloomberg is in country. When we do run the MCCOD training, the doctors and health extension officers are usually very grateful. They come up and tell us that they never understood the importance of the MCCOD, and now that they do, they will do better at it. I've had experiences where I visit the ward to pick up a death certificate for a relative, and I actually look at the form and I ask the doctor who's completed it, it seems you've completed it correctly. Have you had training? And he says, yes, you trained us in April or May or something or other. So it's good. I feel like we're doing something good. We're making a change.
And we're trialling different strategies now in different districts in order to get those notifications in, using different notifying agents at the ward level, different notification strategies, so from paper to electronic methods and using mobile phones. We're trialling all these with better support from a central level, and starting to get more notifications in and starting to get better levels of verbal autopsy. So notification strategies we're trying is old-fashioned paper-based system and mobile phone text messages. There are pros and cons to both. The paper is simpler, but there's time delays, there's ongoing costs. With the mobile phone strategy, there are also difficulties with getting ward recorders to use phones when they haven't used them previously. There are issues with mobile phone coverage, breakage of phones and so on. And in very remote areas, both have difficulties. But we are trialling these different methods. We're getting notifications through both, and we'll be able to do an assessment of what's the best strategy going forward. We are starting to get notifications in using the different strategies and able to get verbal autopsies done by health workers who are getting these notifications in.
So with the verbal autopsy rollout, we've been working in sites where the electronic national health information system has been piloted. So we have 5 pilot provinces and we are working in 4 out of the 5. One of the significant points that we should mention is that each of our sites is completely unique, and we didn't quite expect that that would be the case. 2 of the sites we are working with ward recorders at the ward level as notifying agents. So that's the Alatau district and the Thalassia district in West New Britain. For Western Highlands, we're working in Tambul-Nebilyer district, and we have so far trained only 16 village health volunteers, because of all the provinces in PNG, only 2 have functional ward recorder systems. So we won't be working with ward recorders in any of the other districts that we may pilot in.
So the first verbal autopsy results we're getting in, we've got a little over 100 now, so still very early days, but it's interesting to see that we are getting high levels of ischemic heart disease, high levels of chronic respiratory disease, particularly in middle-aged men, which is probably what we would expect. But even in rural Alatau, we're seeing a lot of non-communicable disease that
yes.
Is perhaps surprising, but PNG is, like many countries, starting to really go through the transition now. So very interesting, very early days, and we're looking forward to pushing ahead in the next few months and getting a higher number of VAs and more certainty with those data. With the data we've collected so far, we've already presented that to the National Burden of Disease Committee and the Population and Monitoring branch of the National Department of Health. They're set up now to regularly assess these data and present them to the Technical Working Group and the CRVS Committee as well, to use these for future policy once we get to a stage where we have the confidence in the numbers of VA data and confidence in the data we're getting out. We'll be pushing to get 500 in the next few months, and then that should give us confidence in
At
the top
least by
5.
March.
Yeah, and that should give us confidence in the top 5 causes of death, which will then be useful for policy.